Adam, I'm quite excited to have this conversation. I talked to Alec Blennis last week. I think that's how you say his last name, who I know you're familiar with. And we had a great conversation. Some things about pain, a lot about lifting. We sort of focused a little bit more on the intricacies of some exercise stuff. So this week, I kind of wanted to do a little bit of a deeper dive into the pain injury side of things, given that that's kind of your specialty. I know you've been doing this for, I think, almost 2 decades at this point, maybe more. Yeah. Yeah, a lot of experience under your belt. And so I just kind of want to start with a brief intro, which is just kind of just express gratitude to you, actually, um, because I haven't been in this industry even a fraction as long as you have. Um, and at first, I think many people on social media find you abrasive, which is, many people find me that way as well. And so in some sense, I resonated with that. I'm a disagreeable person in general as well. But you were the first person to really wake me up to the realities and the complexities that underlie pain, that underlie injury. And you introduced me, I think, more than anyone else, to the concept of sort of being okay with uncertainty and in fact using uncertainty as a sort of guiding principle to be confident as someone who takes their job seriously. And so I want to say thank you to that, because you were one of the first people to be like, Ben, wake up, young child. It's not just about biomechanics. So I want to just say that, and then I want to start with a general sort of question, which is, what do you think, in accordance with that, most people get wrong about pain and about injury? And you can sort of address those separately, because I do believe that there is a distinction between pain and injury. So take that as you will, wherever you want to kind of go with it.
All right. Well, first things first, thanks very much for the invite on, Ben, and thanks for that nice little start. It's very nice to hear that. Flattery will get you everywhere, mate, before we get started. So that's a nice little technique before you start the podcast. Yeah, so what do people get wrong about pain and injury? Where to start? There's probably, a good few misconceptions about it. So let's start with pain first and foremost. So I think, the number one misconception about pain, I think, is that it automatically means something is broken, means there is some structural damage, and therefore you have to protect and not move or not exercise when you've got a pain. And that is a very common misconception out there. It's culturally ingrained, I think, into a lot of people from an early age. Pain means something's wrong, something's damaged, you've got pathology. But it just ain't that simple. Pain is a multifactorial experience, and it can be affected by many, many, many things. Now, we can't say that, things, when they do get broken and damaged, that they don't cause pain, because they do quite commonly. So it is sometimes as simple as saying, when you have pain, it's because you've broken a bone or you've torn a muscle. So we're not going to say that it's never the case, but it's not always the case. And the intensity of the pain is also a poor indicator of the level or the amount of pathology or structural damage that is or isn't there as well. So again, I think that's another common misconception. The more pain I have, the worse my injury must be, or the worse the pathology that I must have. And intensity of pain is a very poor indicator of tissue status, and there's lots of different ways of trying to explain this. One of the nice ways I like to try and explain that and give a perfect example of where pain intensity really doesn't match the level of tissue damage is the classic paper cut or the hangnail. You get this little hangnail and you just give it that little extra bit of a tug, and you move it 2 millimeters further down the finger, and oh my God, it feels like the end of the world, the worst pain you can imagine. And that's a very small amount of tissue damage there. So we know that sometimes you can have tiny, insignificant amounts of pathology and damage and really severe levels of pain and disability. But then we also see the other end of the spectrum as well, the more positive end of the spectrum, when there is a lot of damage and injury to a structure, but there's minimal pain or sometimes no pain at all. And again, a couple of examples I try to use to help explain that. We know People sometimes, they can injure themselves and only know that after the event when they see a bruise on their skin, and they've got no visible recollection of how that bruise has appeared. A bruise is an undeniable visual observation of tissue damage. That I've myself, and I'm sure many people listening, have found bruises on your body. And you got, where the bloody hell has that come from? No recognition of when that injury occurred. So that's a classic example of how sometimes we are not attentive to an injury because of other things going on at the time. We may have bashed into something whilst there was other stuff distracting us. And because our system said we don't need to worry about it, it's not concerning, it didn't bring our attention to the structural damage that had occurred. So, I think there's, as I say, those are the two common misconceptions around pain. It means damage, and the severity of the pain means the more severe the injury is. It's just not that simple. And then what are the
So
misconceptions? Sorry, go on, yep.
yeah, so just to sort of clarify, and I think those were some great examples. Pain is definitely sort of this super important thing, right? Obviously, for normal human function, people who don't have a perception of pain tend to run into issues quite early on in life. And so, with that said, you're sort of speaking to the misconceptions maybe around what pain might indicate. And so I think a lot of times pain is conflated with injury, and sort of you alluded to some examples there where it might not be, or cases where there may be direct relationship. So if we're sort of at a fork in the road and one fork is, pain and one is injury, how do you sort of draw that distinction conceptually?
Um, Again, it can be difficult to do that. It isn't always, they're not two separate entities that can always be easily either, combined or separated. There's a lot of overlap a lot of the times. So when people do have an injury, they often do have pain, but it's about, determining whether it is still safe to carry on despite the pain that they are feeling. Or do we have to consider that the pain now is becoming maladaptive? It's now not a useful protective mechanism, but it's now actually impeding somebody from being able to perform and move on and progress. And it isn't easy or simple to tease this out. And this is something over, let's say, a good few years of my career, I've realised it's not quite as straightforward as saying, you've got to be 100% pain free before you can go back and start training or exercising, because that actually doesn't go well at all. It can actually, as I say, impede a lot of people's progress. But likewise, if you push through pain too much, too quickly, too regularly, that can also have the same effect. That can impede progress as well. So I think, it's a case of just trying to look at an individual case by case basis. It's about looking at the factors around their pain experience, around the mechanisms of injury that they may or may not have had, their lifestyle, their background, social economical status, beliefs, expectations, their psychological variables. All these things have to come into consideration when assessing somebody with an injury or with a painful problem to decide how best to proceed.
So it kind of sounds to me, in many ways, that although something, although pain is something and injury is something that we can assess on an individual level, or rather that we need to assess on an individual level, because there are so many variances or so many distinctions between individuals and their experiences and their perceptions, it does seem like there is this sort of common thread, as I sort of started out with, that there is no simple solution. And um, I think that's a takeaway that many people hear but don't really necessarily internalize, because I hear it oftentimes, not necessarily through the way that people talk in terms of the way that they state things, but rather the questions that they ask, right? So the common question, for example, around things like posture, things like what people perceive to be dysfunction, all those kinds of questions are sort of implying this common thread of I see something and therefore I can conclude something. And so understanding that, one of the things that I find incredibly frustrating, and especially as time has gone on, I have found more and more frustrating, is how we as a sort of lifting culture, fitness culture, tend to pathologize things that are very normal, right? anterior pelvic tilts, to name one. Posterior, and it's funny because a lot of these things actually are in conflict with one another, right? It's like, oh, rounding your shoulders forward is bad, but flaring your ribs is also bad. Pronated feet are bad, but rigid arches are also bad. Knee cave is bad, but knee varus is also bad. Anterior pelvic tilt is dysfunctional, but also having sway back posture is dysfunctional. So I want to kind of go down that rabbit hole, and maybe we can just pick an example because I think all of them sort of fall for similar traps. And if you disagree with that, I'd love to know. Maybe we'll just start with something like anterior pelvic tilt because a lot of people are familiar with that as a term. What are the sorts of problems with pathologizing something like anterior pelvic tilt?
Well, the first thing is accurately assessing who does and who doesn't have anterior pelvic tilt, because it isn't as simple as just doing observation or even palpation assessments, because there is a lot of individual variation in the bony landmarks that we use to assess pelvic position. So when we're often trying to determine which type of tilt the pelvis has on an individual, we use the ASIS and the PSIS on the pelvis, these bony prominences. And we look at the height of them in relation to each other to decide whether one is higher or lower than the other to tell us which way the pelvis is tilted. But there's been a number of studies that show that these bony landmarks sit in really highly variable positions when the pelvis is in a neutral position from person to person. So if you were to put these pelvises in a neutral position and then look at these heights, these bony landmarks, some people's ASISs are higher than their PSISs, but then others are more in level, and then others have their PSISs higher than their ASISs.
Mhm.
So it all gets very confusing and hard and difficult to assess who is and who isn't in pelvic tilt based on our visual observations and our bony landmark assessments. That's the first issue we've got. And then trying to demonstrate, causality of pelvic position in situations of pain and problems, again, notoriously difficult to do. And as you said, it's not just that simple process of saying this occurred after this, therefore the thing that happened first must have been what caused the thing that happened afterwards. That's just classic post hoc reasoning. And it occurs a lot in health and fitness and rehabilitation circles all the time. We look for the reason that somebody's got pain or the reason why they've got an issue, and we just look at the first thing we find, the first thing that was noticed that happened before they had the pain. I bent over and picked up a pencil off the floor. Oh, okay. Well, that bending over must have been the cause of why you got back pain. I'm like, no, it wasn't. It's the 3 years of them sitting down doing fuck all for the rest of the day. That's probably more likely to be the problem. Their sedentariness, not the actual bending over that's the problem. But it's just this classic trait that I think all humans have. We just like to try to make sense of the world. And when things are complicated and difficult, we just tend to jump to the first most plausible, rational thing that we can think of. And it can fool us very, very easily to think that, these postures and positions that we see in people who come to see us with pain are the causing factors of why they've got pain. But when you take a 1,000-mile view, when you sort of take a bigger step back and you try to put yourself out of your own little bubble that we all tend to work in, where we see people from certain populations with certain things, and you start to look at the bigger populations and the bigger literature out there, you start to realize, okay, my worldview now needs to change. What I see in my little experience is only one subset of this. But when we look at the bigger picture, now these things that I thought were associated and correlated and causated now so don't appear to be.
Yeah, and I think that's something that I find a lot of very competent physical therapists end up, talking about or end up thinking in terms of an overall framework, right? It's like if you don't have the experience that says that this one thing may or may not be good or bad for this person, or for example, like if you don't have the experience that says, oh, these two people have the exact same presentation, in theory and through whatever sort of scans, assessments you could do, one person has pain, the other doesn't. You don't have the ability to really actually see two people who are existing in very similar ways, at least from a physical presentation perspective. and yet, they have very, very different experiences. And I think that, just to sort of maybe zoom out and back into exercise, I think a lot of the same things can be said about things like technique. So, for example, butt winking in a squat, rounded backs, in a deadlift, and I want to talk about that in a little bit. Flaring elbows in a bench press, those kinds of things that are commonly seen in the same way as these other topics of pelvic tilting and rounded shoulders. And I think that the reason, and I would like to hear your opinion on this, I think that a big part of the reason that people end up in this place is, number one, is just the sort of indoctrination that people get trapped into with, the social media landscape, and just hearing people, talk about it. But I think another big part of it is just, um, I think we as humans really cling to what makes us feel certain about the realities of anything complex. And so, rather than these things being pathologies of the body, it's almost like they're pathologies of the mind and of our cognition. And that's something that's, I think, can be much more difficult to address. So to sort of put that into a question for you, you've obviously had a lot of patients over the years, I'm assuming, of all different sorts of backgrounds, ages, types of people. How do you sort of, work a person who maybe doesn't have that sort of experience of seeing a tons of different people as you have, and sort of trying to get them to see something that maybe they weren't able to see before. And I'm assuming that, of course, it's highly individual dependent, and how people respond can be drastically different. But my question to you is, how do you sort of deal with it on an individual level? Do you have a sort of framework or a process that you go about working with people with?
Yeah, it's a great question. And I do get asked this quite a lot because they say, it must be very challenging to be able to, try to convince people out of these common mindsets or these common misconceptions that, a lot of the population have. And I say, yeah, it is absolutely hard work. And it's one of the most difficult and frustrating things that I do day to day with people that I see who come in, who have been told by people that they respect or trust, or that they've seen, on social media, again, with people that they trust and respect, telling them these very clear, simple explanations about why they've got pain and pathology, and what they need to be doing about it very clearly and simply, that will fix it and correct it within 3 weeks. And I'm going to have to try and unpick this bullshit from their minds. And I'm not going to say I am successful in doing this all the time, because I'm not. I'm not going to say that it's a simple process, or there is a simple formula for doing it. I have made many, many errors in trying to do it with many patients. I can think back over the years and realize some of the disasters that I've had in trying to do this. And I've learned from my mistakes. And I think, the mistakes have taught me a lot when trying to challenge people's misconceptions and beliefs. You got to go at it a bit more carefully than you probably do when you're on social media. If you're in a one-to-one situation with somebody, you can't be as quite as dogmatic, as forceful, as belligerent, as black and white. You have to be a bit more tactful, and pace yourself as well. You might not be able to do it all in one meeting with somebody. You can't convince people to suddenly change their mindset in a 30 or 60-minute session with somebody. It sometimes takes weeks and months to do that. And I think, the way that I do that in a very simplistic way is to try to get them to respect and trust me more than they respect and trust the people that have given this other information. So it's all about building a relationship, and it's all about, trying to work that first before I start to educate them, give them information that's going to conflict their beliefs and their previous understandings. So I'm a big believer in building relationships with people first before I start to vomit information over them all in one go. And I'd say I see therapists and healthcare professionals and fitness professionals doing this quite a lot. They suffer a lot from what I used to suffer from, and I still do a little bit, what I call the writing reflex. You hear some information that's not quite right, that's a little bit inaccurate, and you automatically want to go, I know something that you don't know, and I'm
Hmm.
going to tell you about that straight away. And this reflex that we sometimes have when we want to correct misinformation just comes across as really sometimes off-putting to other people. So as I've done that many times before and it just doesn't go well. So I have to sometimes sit there and you sort of internalize these feelings. You try not to let it show on your face. You're sitting there biting your tongue and wincing and crying or even screaming inside when someone's telling you about a post they saw on Squat University's page and you're like, ah, God, here we go. What am I going to do now? Okay, all right, okay, I'm just going to sit it out. I'm going to listen. I'm going to hear what they have to say. And then, depending on how it goes for the rest of the session and the relationship you have, you may want to sprinkle in a little bit of slight different information there and see how it's received. And then that can sort of give you a bit of feedback about how you can move forward the next time you see them. People don't change their behaviors and their beliefs quickly. That's the one thing also I've learned. So you have to say, pace yourself with it, be patient. And I think, as I say, just try and work on that relationship building first. Get them to like and trust and respect you. And they'll often start listening to you and acting on your advice and information more so than the other person's advice and information.
Yeah, and to the point of people changing their beliefs slowly, if at all, I find that it almost never happens with more information necessarily, right? People definitely do have to take a leap and experience certain things. One of the things that I was just curious about in your personal experience is sort of over the last, I don't know, obviously COVID was sort of threw a wrench in a lot of things, but with your experience, we'll say in the last, just since you've been sort of, more popular on social media and you've gained traction on there and you have a wide audience, what percentage of people that you see in person find you through the internet versus find you via some sort of word of mouth local? Yeah.
It's probably over 50% now. It's made my life easier, if I'm being honest, as a
Mm,
clinician. A lot of people have sought me out, have sort of already started to have the same sort of mindset and belief that I have because they've been following me for a while. So it absolutely does improve my outcomes and success rates now because people are already liking me and trusting me and listening to me from the get-go.
mm,
So I do find that's quite a unique advantage that social media has opened up for me now. Whereas before, 100% of the people that I was seeing had no idea who I was. They didn't know me from Adam, even
mhm.
though I am. And so they, very much had to have that sort of, getting to know me sort of situation. There's all that little bit of side eyeing, a little bit, I'm not quite sure about you. Whereas now, as I say, 50% of people I see know of me, heard of me, follow me on social media, have the same sort of mindset and belief and want to come and see me because of that. And, that just means we're starting off on the same playing field already at the get-go, which is really useful. Yeah.
Yeah, that makes sense. That's a little, now that I think about it, it makes sense because my experience has been the same. If like a trainer will consult with me in person and we'll be going over some motions, the category of question even and the topic of conversation is just so different. Which is, I think there's upsides to both of those experience, just like in terms of improving my ability and everything to communicate and to teach and those kinds of things. But yeah, no, that makes sense to me. And I would assume that the people now that sort of either find you locally or that find you through, word of mouth, that most of those people are still on social media and that most of those people are still um, getting potentially indoctrinated into believing particular things. But I do sometimes wonder, like, it's always nice when I have an experience with someone who is never on social media because their brain and their entire world, their whole ecosystem is just completely different from mine. And my training partner, actually, he's a professional bodybuilder. He has no social media, so you can't find him if you want to. And his perspectives are just it's so refreshing because so much of the way that he thinks is just so different from most people. I think just purely because he doesn't really spend time, on the internet. Um, and so it must be kind of weird for you to experience this long career of, multiple decades, where, only part of your career has been on social media. And obviously, of course, you've become more experienced and I'm assuming much more competent as the years have gone on. So there's a lot sort of conflating. Yeah, maybe, maybe. But okay, anyway, I'll be done rambling about that. So one of the other things that I wanted to talk about, maybe just to sort of integrate this, pain injury theory that we're talking about, because I often find that, at least on social media, a lot of the times the conversation just sort of stops there, where people will be like, pain is complex, injury, multifactorial, post, end of post. And I would like to take it a step further. So I kind of want to use a previous experience that you have had as a case study, and I think you may know what I'm referring to. I don't want to bring some horrible memories back, but
No, that's okay, mate. My infamous deadlift injury. Yeah,
yeah. So just for context, for those listeners who don't know, can you kind of just talk through first, sort of what the hell happened, and then we'll kind of go from there.
okay. Well, in a nutshell, I hurt my back quite badly picking up a big heavy weight, doing a deadlift. That, in a nutshell, is pretty much what happened. So it was coming up to 3 years ago now. So I think it was August, 2021. So yeah, in August 24, it'll be 3 years. So that's when it happened. And yeah, so it was during deadlifts. It was working up towards a 3RM. And yeah, something went pop in my back as I did it. And although I didn't go and get any imaging or MRI scans, diagnosed based on clinical symptoms of a L4 disc herniation, so slightly higher than the usual one. The L5S1 is the most common disc herniation that goes, but based on my referral of pain pattern, I could tell that the nerve root that was being irritated wasn't the same one that most people get, which goes down into the calf and the back of the leg.
Mm.
I actually got, instead of getting sciatica, I call it femoral attica because it was down the front of the leg, down the feet, the
Ooh.
femoral nerve rather than the sciatic nerve down the back. And yeah, caused me quite a lot of pain and discomfort and distress for a good 3 to 4, probably even longer months. But I used it as a case study and then of one on a little social media experiment because I
Mhm.
managed to capture the event as I was doing it. So I had the initial inciting event, which was useful to see. And then I thought I could show the world how I would go about helping somebody with this issue as a patient. And I'll just use myself as the patient. And so I just sort of showed this process of, trying to focus on the big rocks, as I called it, keeping it simple when it comes to rehab and returning back to activity, focusing on the things that I think matter the most, which is keeping things moving, trying to stop the negative thoughts and emotions kicking in too much, and just have a very simple, pragmatic, graded exposure approach back into activity as pain and symptoms allowed. And it worked quite well.
Yeah. So before we dive into some specifics in terms of sort of your thought process at every stage, because I would like to do that, because I think that, especially when people have that kind of an injury, it can be very daunting to navigate the complexity of that. But before we do that, I just kind of want to make reference to a lot of the intuition with that situation, from coming from people, and I saw tons of comments. It was embarrassing to see how many people went this direction with it. But a lot of the comments were something akin to like, see, Adam, we told you so, brother. We told you this before. We told you it was going to happen. Round back, bad situation. So, can you kind of just maybe address that kind of a claim in terms of why it maybe necessarily doesn't make a ton of sense, and sort of what the alternative perspective on that is?
Yeah, so again, it was a common accusation thrown at me that I brought this on myself. I had nobody else to blame for this injury bar myself because of my terrible lifting technique. And what a lot of them have failed to recognize is that I've been lifting this way pretty much on a weekly basis, if not 2 or 3 times a week for the last 30 years of my life, because I've been doing deadlifts probably since the age of 20, maybe even earlier. And now at 50 years of age, I would say I've pretty much done them consistently on a weekly basis. And this is my first serious injury doing deadlifts. So if you think of all the hours that I've put into deadlifting and the amount of injuries I've had, that's a very low amount of risk reward ratio. And if you're to put it to other things that I've had injuries on, I box, I do running, I do other things as well, getting out of bed in the morning. I've hurt myself so many more times going for a jog, going for a run, getting out of bed in the morning and doing all these sort of normally day-to-day activities. So that, if you're to think of the statistics there, deadlifting with my technique is way, way lower than anything else that have caused other injuries in my life. And then the accusations about me being a bad physio because I got this injury, which is also, a straw man thrown at me, is just absolute ridiculous. It's almost like this mindset that people have that says if you're a trainer or a physio, you can never have an injury, because if it does, it means that you're shit at your job. I'm like, what the fuck are you talking about?
Mhm.
Do you think then that a doctor who gets a cold or the flu is a bad doctor? Do you think a heart surgeon who has, a coronary artery bypass is a bad heart surgeon? There's so many other reasons why people get injured and get pathologies and issues. And the biggest one that everybody overlooks is genetic factors. You can have coronary artery problems not because of your diet or your lifestyle. It can be due to your genetics, just like it is having disc herniations. Genetics is a huge factor for contributing to problems with discs. It's not all just about the environment and the lifestyles we lead. It's a part of it. I'm not going to say it's not. And it is sometimes for some people a big part of it. But for other people, it's a tiny, insignificant part.
Yeah. Right. And so I think a big takeaway from that and from, many of the things we've talked about so far is uh, try your best to look for the variables that you're not reflexively identifying for sure. So I want to kind of look at again this injury timeline. You said like 4 or 5, 6 months. So day one, injury occurs. However you see fit, sort of take us through the process of dividing this thing up into specific phases, if you want to do that, or if that would make sense. Injury occurs. What are the sort of first principles of what do you do immediately? How do you go about your sort of self-assessment, and how do you sort of at least subjectively diagnose, okay, what kinds of things can I do? What kinds of things can't I do? Where do you start?
Yeah, great question. So, in those first acute stages, and normally when we talk of injuries, the acute stage is the first 6 weeks after a clear mechanism of onset of an injury, such as I had. So we use this sort of first 6 weeks, we know we're going to get with an acute injury, traumatic issues or stuff, you're going to get this inflammatory response that's going to cause, sensitization to lots of different structures. It's going to cause the worst amount of pain to begin with, and then it will tail and fade off as time goes on. So the first thing to do is to say in those 6 weeks is often, focusing on managing the pain, managing the inflammation. Everybody gets a bit anti-inflammatory in the acute stages, and I disagree with that. You don't want to be too anti-inflammatory because inflammation gets a bad rep. It's an essential part of the recovery and healing process. And if you're too anti-inflammatory, if you're trying to suppress inflammation too much, it's going to probably have a negative consequence. So we want to try and facilitate, encourage, control inflammation, I think is probably a better term there. And obviously, the symptoms that it creates, which is pain and discomfort. So it's about pain management. It's trying to find ways and means to carry on and function without pissing things off too much, without causing too much pain and irritability. It's not that you can avoid it a lot of the time. When you've got an acute injury, it's never going to be 100% pain free, but you don't want to be constantly poking and aggravating and irritating it. And I got a lot of unsolicited advice from spinal experts out there in these first 6 weeks that were telling me to do this specific exercise for disc herniations, which was the Meakinsey protocols, it's often called. So these are a series of extension-based exercises, and the theory behind this Meakinsey protocol is to reverse the pressure onto the disc herniation to try and push it back in. I mean, it's complete and utter bollocks, basically. And I, based on my biases, I thought, what, this is the one that everybody talks about when you've got a disc herniation. I'm going to give it a try. Did it for about 2 days, and it was just agony. It just absolutely stirred the shit out of my pain. And, I don't mind a little bit of a temporary flare up after you've done a bit of movement, but this wasn't just a temporary flare up. This just felt like it wasn't good. It was just irritating the hell out of it. So I ignored all that advice and said, no, you know what? I'm not going into extension. You know, the thing that helped alleviate my pain was the exact thing that everybody said I shouldn't be doing, which was going into more flexion.
Mm,
So, you know, the Meakin's injury was probably due to, you know, overload in a flexion position. But I actually found that going into more flexion alleviated a lot of my symptoms and pain. And the reason probably behind that, looking into it a bit further and looking at a few case studies that looked at disc herniations dynamically under MRIs, is that we don't always see this repeatable pattern of disc herniations increasing and decreasing based on the spinal movements around it. So
mm,
there are some studies that this talks about the dynamic disc model. So the theory is flexion creates anterior pressure onto the disc, therefore the disc herniation is going to move more posteriorly, whereas extension is going to cause more posterior pressure on the disc and cause the disc herniation to move anteriorly. But there's actually studies that show the exact bloody opposite.
mm,
There are individuals with large disc herniations, when they go into flexion, you actually see a reduction of the posterior disc bulge. And the theory is of this is it's actually sucking it in, it's drawing it in rather than the forces pushing it further out.
mm,
So it could be, as I say, for some people, flexion is the best thing to do with a disc herniation. And for others, extension would be the best thing to do. And again, why this is probably due to there's no such thing as a standard disc herniation. There's so many different variations of, you know, size, location, and I also think I'd say that the fluidity of the disc herniation. I think the ones that are a bit more sticky and thicker, you know, they probably are the ones that are looking to get more this pushing in mechanism. The ones that are a bit more looser and flexible and fluidy, they tend to have this more sucking in approach, I think. So when you go into flexion, if you've got a disc herniation posteriorly, if that bulge, that herniation material is soft and squidgy, I think it actually gets drawn into the disc better with flexion.
mm.
Whereas I think ones that are a bit more stickier, I don't know, maybe need to go in the other direction. But it's a very much individual response. So I tell people with disc herniations, find out which movement you're tolerant or intolerant to. And there's often a direction preference with a lot of disc herniations. A lot of people will either prefer flexion movements in the acute stages or they'll prefer extension movements in the acute stages. And then it's a case of just using that to your advantage to give you some temporary relief.
Yeah, so I would assume on just that point of the potential mechanism that the difference in direction of the bulge could obviously have something to do with, we'll say something like structure of the body, structure of the disc, individual variance, and how viscous the disc is, and sort of what how the viscosity of the bulge is. But then also something I was thinking was, you know, potentially the structure of things like the, you know, posterior bodies of the spine, the sort of back portions of the spine where, you know, the erectors lie. And could it potentially be the case that the compressive effects of something like erector contraction could play a role in sort of not seeing that posteriorly directed fluid? Like I would also assume that that could be a potential mechanism, and also potentially a mechanism for why something might feel better. Um, just to sort of sit on that for a second, have you, just out of curiosity, have you seen people cite or have you seen research that has discussed this mechanism of erectors, quote unquote, shutting off in full flexion? And can you kind of just discuss that?
Yeah, so again, it's a bit of a regularly quoted study that's out there because of its you know, so-called proof that, you know, by going into flexion under loads, it means that if your muscles are not there to stabilize your spine, it's going to cause overload onto the passive structures, you know, your ligaments and your fascia, rather than the muscles bearing the load, and therefore that's why you can get more issues into your discs. But the study has got a major flaw in the fact that it's an EMG study and it's a surface EMG study, and there are some issues in, you know, determining the amount of EMG activity we see and the function of the muscle that we're actually looking at. So it isn't just it's not a linear relationship between EMG activity and muscle function and strength. So a common misconception there with EMG studies is the higher the EMG, the stronger the muscle is working. And it's just not that simple. There's many other factors, confounding factors that will affect EMG signals. And one of them is the stretch and the amount of length that the muscle is under, which tends to affect the EMG signal that we pick up on the EMG devices. So that's the major limitation and factor of that, is that just because we saw a lower EMG signal in those flexion positions, it may be because of the muscle lengths have changed. And therefore we're seeing a lower signal because of that, not because of a change in the muscle's function during those positions.
You're right. Well said. And I would also be surprised if, we'll say someone like John Hack, who's pulling close to 1,000 pounds in a, mostly flex position. I'd be surprised if his erectors were shutting off in that particular case, right?
Yeah, it just doesn't seem to be plausible, does it, either? Yeah.
No. Okay. So we've established sort of first 6 weeks are the acute phase, and you're kind of experimenting around with like, you don't necessarily know in those phases exactly what is best, but you can certainly identify like what's definitely, fucking me up. So I think that's a great place to start. Where do you kind of go from there? So in your personal experience, end range or close to end range flexion felt better. Mackenzie push-ups, felt like shit. Where do we go from there?
So again, the next stage is to say, and this is still within this 6 week phase, but it's getting, towards weeks 3, 4, 5, sort of the timelines. It's now trying to return back into some of the activities that, help from other factors, mindset, your mental health, your physical health as well. So, I tried to get back into the gym as quick as I could do for my own sanity. Nobody who goes to the gym regularly, who hurts themselves in the gym regularly, wants to be kept out of the gym for too long. So I thought, I'm going to be sensible. I'm going to take a couple of weeks off. I'm not going to push things, let things settle down. But then as soon as I can, I'm going to go back in. But just completely changed, what I was going to do in the gym. The intensities were low. Everything was done, without hardly any resistance, if any resistance at all. It was more about just trying to start the process off of just feeling like things are returning to normal as quickly as possible by going through the motions. So I go back into the gym and I start, say, playing around, experimenting with a few things, seeing how I can feel. And one of the things I started doing probably from about week 4 was going back to deadlifting. I was just using the bar just to see how it felt. Wasn't pleasant to begin with. There's a lot of, pain and a bit of anxiety as I was doing it. But I just thought, just let's test it out, see how it goes. Also, see what the response is the day after, which is the key thing as well. A lot of the time, see if there's a major flare up or not, which there wasn't. And then, just slowly progress that. Just slowly, just try to, as the weeks tick on by, just to keep going through the motions. And it's all about, progressive overload. It's just playing around with how much you can do based on the symptoms you feel and the response that it creates afterwards. And that's pretty much what I was doing. I was trying to go back to the thing that injured me as soon as I could, but trying to just gradually build my tolerances up to it by playing around with the intensity.
Now, so you've obviously had a ton of clinical experience. Was there anything sort of along this process? Because I'm assuming that that same mentality basically just scales until you're out of pain, right? It's kind of like do what you can when you can, however you can, scale the stimulus over time to your tolerance level, right? And sort of just continue to move that goalpost forward. But was there anything sort of along this experience, of close to half a year that was really surprising to you? Was there anything that was, like a major takeaway that you maybe wouldn't have had otherwise had you not experienced this kind of injury?
Yeah, absolutely. Couple of things. One, unsolicited advice from other people is really fucking annoying.
Yeah.
Really, really, really annoying. So if you are a trainer or a therapist and you start to give people unsolicited advice, just recognize it's probably not going to be well received. It's often, as I say, comes across as rather arrogant and pedantic. That was my experience as well. And I think the other thing that I focused or noticed more on is the psychological impact of an injury. We always talk about the physiological impact and the pathology and the biomechanics and the structural fact. But I really was surprised at how long those doubts, fears, and anxieties about the resilience and robustness of my spine stuck with me after this injury.
Mm.
So I'd estimate I was returning back to the same weight that I injured my back on around 6 months after I did it. But there was a lot of double talking to myself, getting this little devil on my shoulder to fuck off every time I did it for probably 12 to 18 months.
Wow.
It really took a long time for me to build that confidence up where I went and approached the bar and didn't think, are you sure you want to do this, Adam? You think this is a really good idea today? Why don't you just have the week off? Come on, you don't need to pick up 180 kilos. Take a couple of plates off. It'll be okay. It'll be much safer to do it with a much lighter weight. And I'm sitting there going, come on, fucking, where is this coming from? Why is this still here? And I think, it's something just to recognize a bit more when we are helping people with injuries, that these doubts, these fears, these concerns, they're perfectly normal and natural, I think. But it just did highlight to me that they're just not easily got rid of. It really does take, I think time is the biggest thing. Time and just, a bit of stubbornness, just keep grinding it out, work with it rather than trying to fight with it.
Hmm. Yeah, and I have a similar experience, not from, a specific traumatic gym injury, although I've had my fair share of minor injuries, couple months type of thing. Um, but one of the things that I experienced a number of years ago, I want to say this was in 2019-ish, was I had for about 6 to 8 months this really, really terrible bout of what I perceived to be some kind of sciatica related sensation. I just, as general I can describe it, that's what it felt like. And it was like a left lower back, left glute, left leg type of thing. And I had always tried to solve the problem. This is kind of where my experience as a trainer and someone just studying this stuff sort of connected with that experience of pain, and then also finding your page and your information. It was all sort of this terrible storm of things, right, happening simultaneously, where I would just spend an endless amount of time trying to, fix the problem. And, what does this person say about this problem? What does this YouTube video tell me about this problem and how I can fix it? Is it my glute med? Is it the opposite side fascial layers? Is it my same side QL? It's just like the endless amount of things that you can find yourself diving into is really troubling. And what I came away from the experience with was that none of that shit worked. And the only thing that helped me, seemingly, was trying to forget about it and trying to continue to lift, and just going back to like regular barbell squats, regular barbell deadlifts. And lo and behold, time sort of told me that that was a great thing. So a very similar
Totally agree.
experience. Yeah,
Yeah,
very, very
totally
similar.
agree, Ben. I think we are our worst own enemies sometimes for getting in our own way to our progress and recovery a lot of the time. And I don't think that a lot of the well-meaning advice and information out there helps with that as well, because I also think a lot of it gets in the way as well.
Hmm.
A lot of people, they come up with these ideas and these solutions and these methods and these fixes because they do genuinely want to help people, but they're just trying to reinvent the wheel. And sometimes I think, as I say, it just ends up getting in the way, just adds more confusion and complexity to things that, just as you said, really just need time and a little bit of stubbornness and a little bit of ignoring and just cracking on and not overthinking it too much, because that is the biggest barrier that we have a lot of the time. Our minds can dictate a lot of what we perceive and what we feel in our bodies. And if we're constantly hyper vigilant and focusing on things, it absolutely just delays things. And I tell a lot of patients that, a lot of their way to getting back to normal is just having a therapeutic break from therapy.
Hmm.
The
Hmm.
last thing you need is more fucking physiotherapy. Okay, you're at a level now. Okay, you're not perfect, but you're at a level now where there's nothing else needed to be done. And they're like, what? But I'm not 100%. What am I going to do? Yeah, you just crack on and time will sort that out. The last thing you need is more complexity and quick fixes and information about stuff that's only going to probably just get in the way.
Hmm. Yeah, well said. And I think that my current level of sensitivity to that kind of messaging of, to our earlier conversation of pathologizing particular postures or positions, my sensitivity to that, I think, is based on my own experience of none of it working. And then also, and this is something I find particularly concerning, the idea that many people who don't have pain, who aren't in these kinds of situations, they get sold this story of, you have this particular problem and I can solve it with my content and I can solve it with my program if you only buy it for several hundred or $1,000, right? And that to me, that starts to dip into the sort of, immoral territory, I think, with this stuff. But even just making pieces of content, were you going to say something about that?
Yeah, I used to think the same way, but I've over the years I've realized that I don't think there's a lot of maliciousness out there with people
Yeah,
wanting to help people. I just think
agreed.
there's a lot of ignorance, all right? There's a lot of people out there that are just, say in their little bubble. They're not well read. They haven't understood the complexities. They're not tolerating the uncertainties very well. So they come up with these ideas and these methods. But I do still think it's from most people from a well-meaning place. As you say, and it does sell quite well because who doesn't want simple fixes and quick solutions to things? So it has that sort of positive feedback loop as well, where it has sometimes keeps people still doing things. So yeah, I always try to not see maliciousness in things immediately. I'm not going to say there aren't people out there that are unethical and immoral, because there absolutely are. You can sort of pick that up after you have a few interactions with them sometimes, but a lot of people, it's not there.
Yeah, totally agreed. And I think that's a much we'll say healthier perspective to take. So I just want to finish things up here with a quick question. Perhaps it won't be quick, but I always kind of like to ask people, what in the last sort of 6 months to a year have you changed your mind about in relationship to any of the things that we talked about? I would like to stick to, fitness, anatomy, physio related topics rather than topics about, let's say social media or general psychology. So anything that you changed your mind about, what is it? And, why did you decide to change your mind?
Yeah, sure. So I think the one that's probably the biggest shift in mindset that I've had in the last year has been my thoughts and interactions and approaches with flexibility and mobility work and training. So I was a big anti-stretching kind of guy. One, because I hated doing it and it was my own biases getting in the way of me understanding and looking at the bigger picture again. So I hate stretching. I find it really awkward. I'm quite an active, stiff person as well. And if I'm being honest, I'm quite jealous of people that are able to put themselves into these positions and turn themselves into pretzels. So I've always had this sort of negative view on flexibility. And then a paper came out in 2019 that stroked all my biases like a soothing lover that was taking me out for the evening. It was so good to read, and it was by Nuzo in 2019. And it was this: is it time to retire flexibility as a major measure of health? And it went through all this critical review of why flexibility was first thought of to be focused on and important, and then he came up with all these counterpoint arguments, and it just stroked all my biases. So I put this paper out and said, oh, look at this, here you go, this is telling me everything that I thought about flexibility. It's proving me right. And I got so much kickback from that it actually made me take a step back and go, hold on a minute, okay, perhaps there's something else I need to look at here. And I've got to give credit to, and if you want to talk to somebody else, I don't know if you have talked to him, is Dan Van Zandt,
Mhm.
flexibility research guy. He is the guy that perhaps, helped me the most understand a bit more of the nuance and the complexity around the effects of mobility and flexibility work and the benefits that it can have for certain individuals in certain situations. So yeah, that has been a big shift in my mindset to the point now where I am dedicating some of my own time now, not just doing running and boxing and strength training, but actually having some dedicated time focusing on mobility work. And
Wow.
I'm not going to say I enjoy it because I don't, but it is something that I am trying to get a little bit better at, and it's something now that I'm promoting more in my consultations with other people as before. Whereas everybody was saying, should I do this? I'm like, nah, don't waste your time on that. Focus on this instead. Now I've got a slightly different approach to it.
Mm. Yeah, I resonate with that a lot because like you, my bias is sort of has always been anti-stretch, anti-mobility. I will admit that I think my bias still tilts in that direction. Not because I don't think that it could be useful or important for some people, but mostly just because I find that people end up emotionally attaching themselves to certain modalities and certain sort of preparatory activities that may end up just being a complete waste of time. So I do think that there is always going to be that side of it as well. But my fiance is a dancer, and dancers are like Gumby, and she is someone who has historically had a ton of back related issues, which I had always assumed was just because of how flexible she was. I didn't think that, oh, maybe it's potentially the fact that she's dancing for 5 hours a day, 6 days a week. Let me just blame this thing instead. So I like you am interested in that, and I'd love to talk to Dan. So I'll reach out to him and we'll have a conversation hopefully. So yeah, thanks for bringing that up, and that would be something I would love to tackle. So I know that you have a lot going on Instagram, so I'll link your Instagram right in the show notes. People can follow you there, find your stuff. Is there anything that you would want people to know about sort of what you have going on, or any projects you're currently working on?
No, nothing new at the moment. My life's been a bit chaotic for the last sort of 6 or so months with various things going on in my personal life and background. So things haven't moved much forward. I had some plans for doing some more online education courses for young therapists out there that have been put on ice. So hopefully they are coming out in the future, because I do get a lot of young physios asking me, and not just physios, other healthcare professionals as well, about how to navigate this uncertainty and complexing and conflicting area that is social media. So I was adding some plans for that, but no, at the moment the only thing I tend to do is do my regular 2-day course on the painful shoulder, which is an area of specialism of mine. So I've got an online version of that, but I also do it face to face at various locations around the world as well. So if you want to head out and check that, you can see it on my website, which is thesports.physio.
All right, Adam. Thanks so much for your time. I really value it, and maybe we could do this again at some point in the future.
Yeah, great chatting, Ben. Good to meet you at last, and thanks for the invite.